And this is the second lecture of today. This is going to cover more of what ATI has pointed out, but we're going to more depth because we're looking at the diagnostics now for immune system. I should put ATI. I'm going to put ATI right here just so people know what we're doing here. Keep an eye on this guy, the bug man. Okay, what we want to do with this lecture is we're going to cover a little of the physiology. We're going to go into a little more detail on some of the things I talked about at 9 o'clock. But then we're going to look at a couple different tests. When it comes to just directly testing the immune system, there's only a couple tests we really do mostly for allergic reactions. When it comes to would somebody have flu or COVID or whatever, we're not really testing the immune system. We're testing for that particular pathogen. So we will cover these two tests just briefly. Most of us have probably seen or heard of this before. Someone has hay fever, or they have an allergic reaction to something and they're curious what it is. So they'll go in for a blood test or a skin test to detect that allergy. What's more important is I want to talk about the diagnostic tests and what those means. We have hit on CBC. There's two big primary tests that doctors seem to run on anybody that walks through the door. One of those is the BMP, basic metabolic panel, or an expanded version of that, which includes liver enzymes, is the CMP, the complete metabolic panel. But that looks at the electrolytes. What's your potassium, your chloride, your sodium, stuff like that. For that test, they break the blood down into its tiny components. The complete blood count, however, they don't. They put it in a machine, a centrifuge, and they separate out the different parts of the blood, the red blood cells, the white blood cells, the plasma, and they test those separately to see how many of each of those we have. Now, a basic CBC is going to tell us how many red blood cells we have, how many white blood cells we have, and what our platelets are. And that's basically all. If we want to go into more detail, we have to get a CBC with a differential. And around the hospital, you'll call them CBC with a diff, CBC with diff. And what happens is that the differential is we take those white blood cells and we break them down into individual components, which we spoke about at 9 o'clock. Neutrophils, basophils, eosinophils, etc. I don't know if we've talked about those individual components or not, but we're going to talk about them now. Now, I should have specified the normal WBC count in white blood cells is normally 5,000 to 10,000. What we're talking about here during this lecture are all white blood cells. We're not talking about RBCs. We're not talking about plasma. We're not talking about platelets. But I need to clarify this right here. Is the normal WBC count that you will find in your basic CBC is 5,000 to 10,000 millimoles cubed. I wouldn't spend a whole lot of time trying to remember what millimoles cubed means, but basically 5,000 to 10,000. On a lot of blood tests, they will cut off to 1,000 sections. So you'll see a lab test that says CBC, white blood cell, WBC is 5.3. And what they're saying is 5,300, but they just cut off the thousands for the sake of convenience. Now you notice I say it's about the normal number of WBC cells, because different lab tests go to different labs. Different labs test differently, so different labs will have different normal values. So if you may be looking at a lab sheet at your next clinical for a patient and it says the normal WBC count is 4.5 to 10.5. Well, every lab has their own normal. So that's why none of these normals are absolute. They're all about. And that's true of all blood tests because every lab uses a different methodology for testing, so their normal values are going to be a little different. But on every lab result, every lab sheet, it will give you their normal. So every time you get a lab result from a patient in the hospital or clinic or wherever you are, it will tell you what their normal is. Just a general ballpark, though, is the white blood cell count is going to be 5,000 to 10,000. So if somebody comes back with a WBC of 2,000, it doesn't matter what lab it is, that's low and that's bad. Usually what you'll find is somebody will develop an infection. So you'll look at their WBC, you'll look at their CBC, and under WBC, you'll see like 11 or 12. Ooh, large number of WBCs, which means they're fighting an infection. And that's usually what the doctors and the nurses do. They look at the CBC and they say the WBCs are high, way high. Okay, they're fighting an infection because something has launched your body's immune response into high gear. That's the important thing to remember. Any questions on that? Moving on. Before we dive into the different types of WBCs, just kind of remember there's a couple terms that you're going to see thrown around a lot. One of those, leukopenia. Now, penia meaning less than. So leukopenia means your WBCs are low, usually less than 4,000. So if you get a WBC back from somebody and their WBC is, or their white blood cell count is 2, well, they have leukopenia. Now, a lot of different things can cause it. A massive infection, and this is a very late stage in infection where all the WBCs have been burned up. You know, they started out high and then it kind of crashed. Bone marrow suppression, we'll talk about that a little later. But like if you're doing radiology for cancer treatment or chemotherapy, that can also suppress your white blood cells. More often than not, you'll see leukocytosis, cytosis meaning greater than, and that means that you have more than 10,000 WBCs. So if you're looking at 11, 12, 13 on your WBCs, they're fighting an infection. Questions on that? Nope. Moving on. We're going to look at 5 different types of white blood cells. First and foremost, the most important is the neutrophil. And you remember from 9 o'clock, we were talking about the neutrophil. Well, when we run a WBC or a CBC with differential, it's going to break down those white blood cells for us. And neutrophils are the biggest component. Those are most of what your white blood cells are. 55 to 75% of your white blood cells are these neutrophils. And if you remember from 9 o'clock, that's when these guys go and gobble up the bad guys and die. They're a one-time killer. And then they just kind of float to the surface of the skin where the body rejects them because they're a waste product. And that's where we get pus. So that's the vast majority of your white blood cells. They're the first line of defense. An increase in the neutrophils, when you see those in a CBC with a diff, they're increased. It will usually indicate a bacterial infection. Trauma sometimes causes that. And rheumatoid arthritis, which we will talk about later, that's where your body attacks itself. So your body will increase the let's try that again. Will increase the number of neutrophils, but those neutrophils are attacking your body, which is not a good thing. It's a very bad thing. Decreased sepsis. There again, sepsis is a form of shock. We'll talk about that at a later date. Very serious. The hospitals are getting very serious about sepsis. I'm going to have to look and see when we talk about that, but later this quarter, we'll be talking about that. Radiation therapy. There again, radiation is, hitting the bone. So the bone's not producing as many neutrophils as it should. It can lower your level. Chemotherapy and flu. Flu, it's a viral infection. So usually the neutrophils don't have a whole lot to do with the viruses. They're mostly a bacterial combatant. When we get into viruses, that's when your adaptive immune system takes action. So couple things there to remember. You might hear this thrown around. Don't bother memorizing this, but this is something you might hear in the hospital: left shift. When the doctor says there's a left shift, what they're doing is they're looking at the number of mature neutrophils versus the number of immature neutrophils. So when someone gets an infection and it's getting worse, the body will produce a massive number of neutrophils out of the bone marrow, but they need time to mature. And so there's this little scale, and when the scale went up on the left side, meaning there's more immature neutrophils than there are mature neutrophils, the bar graph on the left was bigger than the bar graph on the right. And that's why doctors started calling it a left shift. What it's basically saying is that you're in the early stages of an infection, and it's kind of a warning. Oh, wow, this person's fighting a massive infection. We need to hop on it right now, especially if you're looking at sepsis, which we'll talk about at a later time. I'm just throwing out there so you guys know what they're talking about when they say left shift. It's nothing that I will test you on. Here is the second greatest component of your white blood cells. These are the lymphocytes. And the lymphocytes are the T cells and the B cells, which we all know now are part of your adaptive or specific immune system. Now, these guys will increase during a bacterial or a viral infection. These are the heavy hitters. These guys go after the mononucleosis, mumps, measles, hepatitis, some cancers, because remember the T cells can identify when a cell is sick, aka a cancer cell, and kill that cancer cell. So these guys are 20 to 40% of your bloodstream, white blood cells. They can be decreased during leukemia or sepsis. There again, we'll talk about sepsis later. But in leukemia, it's a cancer within the bone, and it disrupts your whole production of white blood cells. Those are the two big ones. We'll get into the smaller ones now. But the smaller ones are still important. Monocytes are a small percentage, 2 to 8%. These are the ones, remember, that turn into macrophages, which are very similar to the neutrophils, where they just gobble up the bad guys. But an increase in that on the test can indicate such things as tuberculosis and mononucleosis. Some of you may, when you were kids, had a case of mononucleosis. Just makes you extremely tired. But a doctor may look at the monocytes and see the increase, and he may decide, oh, okay, they may have mono, so we'll test for mono. And there is also a tuberculosis test, but I think that tests for the actual tuberculosis antibody. It's not testing for monocytes. But if someone's got a cough and their monocytes are high on their CBC with DIF, might give them a TB test, just to be sure. High incidence of TB coming back, drug users, not so much HIV anymore because we're treating that effectively, but homeless, TB is still around. Decrease, there again, is a cancer, aplastic anemia, cancer treatments. Corticosteroids. When we say corticosteroids, think prednisone, think solumedrol. Solumedrol is IV, prednisone is pill, but we use this as an anti-inflammatory. It's very effective anti-inflammatory, but it's also got a lot of bad side effects to it. Eosinophils. This is the fourth WBC that you will see on the test. When you hear eosinophils, think hay fever and asthma. They're a small percentage, 1 to 4% WBCs, and they mostly they secrete a lot of histamines when they get activated. And the histamines are what cause your eyes to turn red, your nose to water, the sneezing, all that stuff. And that's why for hay fever, you take an antihistamine. We're trying to cut those histamines back. Basically, what's happening is the eosinophils are overreacting to some type of allergen, usually like hay fever, something you eat, what's the big one? Gluten is the big thing now. And there again, something that can cause the reduction is corticosteroids. But eosinophils, think hay fever. Eosinophils, I think is how you really pronounce it, but it's kind of hard to say. Hay fevers and asthma. Now, basophils are a smaller percentage, 0.5 to 1% of WBCs. Now, when you think basophils, these guys are the ones responsible for an anaphylactic shock or anaphylactic reaction. Two of the most common are a bee sting, and the basophils can overreact, causing swelling of the windpipe, which is why anaphylaxis is so dangerous. Somebody gets stung by a bee, they swell up like a balloon, and their windpipe can also swell and swell shut to where they can't breathe. And that is why people who are susceptible to bee stings need to carry an epinephrine pin with them, because epinephrine will counter these the allergic response, diminish the swelling and relax the windpipe so that they can breathe again. Another example of this is shellfish. I'm sure you've probably heard of people eating shrimp or crab, and then suddenly they have an anaphylactic reaction and they can't breathe anymore. So they're calling the medic and trying to get them some epinephrine to get them to breathe again. Now, a mild reaction, and I've had this with a certain foods, is a rash and maybe some like a scratchy throat. For those, usually an antihistamine like Sudafed, or the more common treatment for that is Benadryl. So if your child at home, eats a shrimp or something and he's breathing okay, but he's starting to get a rash all over his body, Benadryl is a good way to take care of that. If you need something stronger, you can come to the ER or to their doctor, and he will probably give them Solumedrol, which is a corticosteroid, which I said is like a wonderful anti-inflammatory. And you'll study that more in your pharmacology. So those are the 5 right there. Are there any questions on those 5 tests? Are those 5 white blood cells? No questions? You got them all down pat, right? Piece of cake. So here we're going to look at the 2 tests, blood test and skin test. Blood test, remember in the last lecture, what is an IgE? It's an immunoglobulin. What is an immunoglobulin? It's an antibody. So remember I said we were probably going to be concerned with the immunoglobulin IgE, because that's what most pops up usually in allergic reactions. The overabundance of IgE can result in asthma, hives, tinnitus. Tinnitus is ringing of the ears, GI upset, dermatitis, i.e. rash, angioedema, when your face swells up. See, all these are things you will see in like a bee sting or an allergic reaction, right? It's a simple blood test. And we don't want anybody to take an antihistamine or anti-inflammatory before the blood test, because that will suppress the IgE, and we're trying to test the IgE. So that's what this down here means, is don't take any prednisone or any histamines before the blood test. And then what they do is they take that blood and they test it against different types of allergens. And you'll see how that works when we get to the skin test to make it a lot more clearer. This is nice because we're not scratching the whole body full of allergens and stuff. The second test is a skin test. Some of you may have even had this at one point or another. I'm going to flip to the next chart just to give you a really good idea of what that looks like. Basically, the doctor goes through and he'll take and either scratch or inject an allergen under the skin surface in all these spots right here, keeping a chart that says what each of them is. And then when you develop an allergic reaction to it, voila, they know what allergen you are allergic to. This guy's having an issue because he's got a whole bunch of them. Probably he might have had hay fever, and these are different strains of hay fever. So, you know, he may not be allergic to a lot of different things. These are just different types of the same thing. But then he's also got some reaction here, and he's got some reaction over here. So whatever those translate to be is what he is allergic to. Same indications for that as a blood test. I mean, same things I was talking about: dermatitis, hay fever, angioedema, et cetera. They're the same reasons. I mean, if you have these things constantly and you can't figure out why you're getting these reactions all the time, you'll go to a doctor and have them perform one of these 2 skin tests. As a nurse, a couple things you want to make sure. You want to make sure the back is clean. There will be a procedure there. It might involve chlorhexidine or that red stuff. I forget what it's called. But anyway, you got to clean the back thoroughly and make sure it's a perfectly clean slate to start with. Also advise the patient that they have to stop any antihistamines or corticosteroids for a period before the test. 2 to 14 days, that will be determined by the doctor. The doctor will tell you how many days before that test they need to stop those things. And you also have to monitor the patient closely for about 15 or 30 minutes after the test. If he has a severe reaction to one of those allergens, it could throw them into anaphylactic reaction or anaphylactic shock. So you need to be there to administer epinephrine or whatever is necessary if he has a really severe reaction. Usually they're using a minute amount, so it's just going to result in a red spot. Is that all I have? I believe that's it. Yep. Any questions on that? I know that slide was really short and simple, but I wanted to go into more detail on the different types of white blood cells. Are there any questions on this? Any slides you want me to go back to? Okie dokie. I will stop the share. If there are no more questions, I will stop the recording.